and will be available after the session. All right, let's get started. Welcome to NJSL Presents. My name is Luz Villarreal. I'm a reference librarian here with the New Jersey State Library. I help present NJSL Presents. I'm happy to introduce Dr. Kathleen Bornhoeft and Dr. Mona Saleh. Dr. Bornhoeft is a board-certified family nurse practitioner with more than 30 years experience in the nursing and healthcare field. She is also a member of the Menopause Society, an organization which maintains resources to locate certified menopause providers in your area. Dr. Bornhoeft received her doctorate of nursing from Drexel University and has worked as adjunct faculty for the College of New Jersey's Graduate Nurse Practitioner Program. She has provided primary care as a full-time nurse practitioner for the past 25 years, with a special focus on women's health issues from contraception through menopause. Dr. Mona Saleh is a gynecologic oncologist from Mercer County. She received her medical degree from New York University's Grossman School of Medicine and completed her fellowship in gynecologic oncology at Icahn School of Medicine at Mount Sinai in New York. Dr. Saleh's clinical interests focus on cancers and precancers of gynecologic origin. She has special interests in minimally invasive surgery and improving access to cancer care for all communities. A few housekeeping items before we start. A reminder that you can submit questions at any point during the presentation. You can do this using Zoom's Q&A function, or you can type your questions directly into the chat. Dr. Saleh has also provided a PDF handout to go with this presentation. We'll be dropping that in the chat once we're done with the introduction slides. When you exit the Zoom after the presentation, you'll be prompted to fill out a survey. Please do so. We appreciate your feedback and incorporate it into future programming. I'm now very briefly going to go over your available Zoom controls. This is what your screen should look like now if you're on Mac or Windows. It may be a little outdated, but everything should functionally be the same. If you're on a mobile device, it may also look different, but everything will, all the controls are essentially the same. In the left-hand corner, you have your audio settings. In the case that you're using a headset or earbuds, you can adjust those settings here. If you're having any issues during the session, you can click the raise hand button in the center, and I'll direct message you to do our best to resolve your issue. On either side of the hand, we have the Q&A and chat options. You can use either to submit questions. Again, you could do so at any point during the presentation as mentioned. That's it for housekeeping items. I'm happy to turn it over to Dr. Bornhoeft.
Hello, everyone, and thank you so much for signing up for this. This is a topic that's near and dear to my heart. It's, so common for every woman that she has to unfortunately go through perimenopause and then menopause. But I want to try to shed a positive light on this topic. And the one thing I want you to get from my information today is that it's a unique experience for every woman. It's different for every woman. So I look forward to your questions at the end, and hopefully I can inform you in some way, shape, or form on this topic. So let's start. So I like to call it a menopause journey. It's not the end. I feel like it's the beginning. I'm sorry, let me go back. Happen. Here we go. And I love this picture because it's the beginning of a new chapter filled with wisdom, strength, and joy. And I just love that because before you go through menopause, it's often scary. You hear your mother or your aunts or your grandmother telling you stories, and it's kind of scary, but take it from me, it's not the end. It's the beginning of a beautiful new chapter. And if you have a positive outlook, it's even better. So most of the information today comes from the Menopause Society, which is leading the conversation on menopause. They're everything menopause. They have many, many members, thousands of members. They have certified menopause providers. And at the end, my last slide will have a link. You can click on the Menopause Society, and there's video series for all women on every topic in menopause that I'm going to talk about today. And they're quick 15-minute videos, so informative. So we're going to talk about the definition of menopause and the most common issues and symptoms. We're going to discuss treatments, lifestyle changes, supplements, and hormonal and non-hormonal medication treatments. So first thing I want to say is don't Google or Facebook. I tell a lot of my patients that I know Google's out there, and I understand there's information, but most of the information is not accurate. It's not evidence-based. So use reputable sites such as the Menopause Society, the American Cancer Society, your primary care provider with menopause and hormone knowledge. If they don't, you want to find somebody who has, you know, understanding and menopause knowledge, GYN specialist or certified menopause provider. And I'll show you how to get in touch with them. So what is the definition of menopause? It's the cessation of menses for 1 year. A lot of women come in, they say, I haven't got a period in 6 months. I know I'm in menopause. Unfortunately, 12 months. I've had women who didn't have a period for 11 months, and they got their period again. We had to start all over. So 12 months, no period, menopause. The average age is 46 to 51. There are some outliers, in the early 40s and in the late 50s. Before 40 is called early menopause. That's the proper definition diagnosis of early menopause. And perimenopause is transition before menopause, where your estrogen levels start to decline. And it's different in every woman. Sometimes it starts in their 30s, sometimes not until their late 40s. And then there's induced menopause when you have surgery to remove ovaries, or radiation or chemo. So the journey is a third to a half of your lifespan. So every woman's experience is unique, and that's the most important topic or concept that I want to convey to all of you today. Every woman is different. Most of my women that I've cared for over the years actually sail through menopause and do very well. It can bring sudden, unexpected changes, and it can impact your physical and your mental health. And there's no roadmap for navigating menopause. There's many conflicting opinions about the best approach. I'll try to give you the evidence-based, what we've studied, what research has shown. So, and again, another important, take an active role and make informed decisions in your menopause journey. Find a provider who's knowledgeable and has experience in caring for women going through menopause. Some physicians or nurse practitioners really don't have a lot of experience with that type of patient. So you want to find somebody who, is on the same page. So some of the topics today, we'll talk about the most common overall symptoms, which most of you can guess. One of them is hot flashes. Treatments, including lifestyle changes, supplements, hormones. We're going to talk about mental health a little bit, sexual health, bone health, and heart health. Nothing too detailed. I want to keep it light. There's so much to know, but this is just skimming the top. If you need more information, please let me know or go on the Menopause Society website. So one thing, there's research out there. There was a women's health initiative that started back in 1990s, and there was 160,000 women. They followed them for years, and they came out with some information that wasn't 100% true. They found that hormone therapy did not increase cancer risks or mortality rates, which is true compared with placebo. But they sent out statements that said it's close enough that we think hormone therapy may increase the risk of breast cancer. Later on, we relooked at the studies, and they found that wasn't 100% true. But unfortunately, a lot of physicians and gynecologists decided not to prescribe hormone replacement therapy. Again, new information, new studies, much safer. There is a risk, but you have to talk to your doctor about it. So don't be scared about hormone therapy. Bone fracture risk among hormone users was 30% lower in that study. So hormones did protect bones. If you're concerned about osteoporosis, if you have a family history, if you've had fractures, hormone therapy may be the answer. So more than 10 years of use of hormone therapy was associated with a significant reduction in risk of Alzheimer's disease. So that was another piece of information that came out of that study. So there's a few FDA-approved uses for hormone therapy, and one is hot flashes. One is treatment of genitourinary syndrome of menopause, used to be called atrophic vaginitis. I did not like that. I like this better. It's a nicer word. A lot of women don't talk about it. Doctors don't ask about it, but it's very common in menopause. It's also approved for prevention of osteoporosis, not treatment, and treatment of hypoestrogenism caused by early menopause or bilateral oophorectomy, which is removal of the ovaries. So out of the way. Whoops. What happened? Sorry. Can't get my slides back. There we go. I'm not sure what just happened.
We can still see your slides, Dr. Bornhoeft.
Oh, you can?
Yes, yes.
I don't know why I can't see them. Whoops.
Well, now they're fake.
I lost my slides.
Did you try the Alt tab? See if they're anywhere on the screen.
So I'm going to start all over here. Share screen. Here we go. Okay.
Oh, yeah.
So back to, yeah. So just some information from the American Cancer Society, another resource that's good for you to look at, the women's baseline risk of breast, endometrial, ovarian, and other types of cancer, and how much this might be affected by hormone therapy is something you should talk about with your provider. Every woman is different. The risks of other serious conditions affected by hormone therapy that aren't covered here, like heart disease, stroke, and blood clots, and what other medications might be used to treat menopause symptoms. You want to worry about safety, and that's something you should talk to your provider about. The most common symptom is hot flashes, often the most recognized and reported bothersome symptom, vaginal dryness, sleep disturbances, mood and memory changes, sexual dysfunction, and weight gain. And these are common for most women. Most menopause symptoms will improve after menopause, even without treatment. Like I said, most of my women sail through menopause, don't need anything, but there are many women that do have a problem and really want to talk about hormone therapy, supplements, lifestyle changes. Many factors affects how much distress the symptoms will cause, and women must decide whether the symptoms are bothersome enough to seek treatment. Back to every woman is unique. Every journey is different. Some women sail through, some women do not. The transition looks different for every woman. So hot flashes, feelings of warmth associated with flushing and sweating. 80% of women have hot flashes. They last 7 to 10 years, I'm sorry to say, on average. They can be mild and they can be moderate and they can be severe for a while. They contribute to your mood and your sleep issues, which may affect your quality of life. What helps? Lifestyle, healthy diet, weight loss. CBT, which is an interesting new way of therapy. It's a way to push out bothersome thoughts and put happy, healthy thoughts into your mind. Acupuncture, hypnosis, cooling techniques, exercise and yoga, meditation and mindfulness, paced breathing, relaxation techniques, and to trigger avoidances that may cause hot flashes, such as alcohol, caffeine, spicy foods, or hot foods. So there's dietary supplements. There's limited data to evaluate the effectiveness, but some women have used black cohosh, cannabinoids such as marijuana, chasteberry, dong quai, evening primrose. I'll let you read those. And there's a NCCIH, which is the most reputable all things supplement if you're interested in looking at any safety issues. So it's nccih.org. There's only two non-hormone medications approved by the FDA to treat hot flashes. One is called Paxil. You may have heard of it. It's an antidepressant, but at low doses, it's called a selective serotonin reuptake inhibitor. At low doses, it works to stop hot flashes. I've used it. Another one is called Veozah, a non-hormonal option which belongs to the neurokinin B antagonist class, and it's developed specifically to target hot flashes. In addition, there's other non-hormonal medications for other conditions that have been used. Certain antidepressants, gabapentin and oxybutynin are medications that are used for hot flashes if you don't want to go the hormone route. Hormone treatment in healthy non-smokers, low-dose oral contraceptives are sometimes used through the transition for women that are starting to go through menopause, but are having heavy bleeding, lots of hot flashes. Low-dose oral contraceptives may be used. Hormone therapies, FDA approved as first-line therapy for relief of hot flashes and is most effective. For these symptoms, estrogen therapy is given as pills, patches, gels, or creams. Bone health. Bone densities should be ordered after menopause. Postmenopausal bone loss related to estrogen deficiency is the primary contributor to osteoporosis. I love that picture. Normal healthy bone on the left, osteoporosis on the right. And that's what happens if we don't take care of our bones. Calcium and vitamin D, very important. Up until 30, you have to strengthen your bones. Once you're 30, you're just reinforcing and preventing bone loss. So after menopause, it's very important. Risk factors for osteoporosis include advancing age, genetics, family history is a very strong risk factor. So if your mom or your grandmom had it, you're likely to have it as well. Smoking, low BMI, low body mass index, and many diseases and drugs that can impair bone health, such as thyroid, chronic steroid use. So genitourinary syndrome is defined as a collection of signs and symptoms associated with estrogen deficiency that can involve changes to the vaginal labia, the opening. It causes dryness. Sometimes women get UTIs. Sometimes women have pain. During intercourse, it's dryness, irritation, and burning. It can be mild and it can be debilitating. It's underreported. A lot of women don't talk about it. They're saying it's probably between 40 and 84% of women actually have it. It does not happen to everyone. Again, everyone's journey is unique, and some women do not have it. Thorough history and targeted physical exam is essential for proper diagnosis. So I ask all women, mostly because I do GYN exams, and there are safe and effective treatments for nearly every cause. They call it dyspareunia. So non-hormonal treatments, you want to avoid using soap, bath oil, bubble baths around the vaginal area. There's some vaginal moisturizers over the counter that work well. Wet Platinum, Replens. You want to buy one that has the least amount of ingredients so that it doesn't burn, so it's not irritating, but they work well. Regular painless sexual stimulation alone or partnered may help preserve vaginal function by increasing blood flow and secretions. So you can use a water-based, silicone, or oil-based. There's something called ospemifene, the non-hormone oral medication. It's another selective estrogen receptor modulator. It's approved to treat symptoms of genitourinary syndrome of menopause. This is fairly new. It alleviates vaginal dryness and pain with sexual activity. So there's a whole list of those. So hormonal treatment, we could do systemic when hormones are delivered through the body via pill, patch, spray, or gel, or a vaginal ring. It's called systemic. Systemic doses are absorbed into the bloodstream at high enough levels to have significant effects in widespread areas, which is needed to treat symptoms such as hot flashes. So systemic, very effective for hot flashes, can have other benefits such as protecting your bones. It can help vaginal dryness. They also carry risks such as blood clots and breast cancer, slight. The breast cancer risk usually does not rise until after about 5 years with estrogen plus progestin therapy, or after 7 years with estrogen alone. Again, every woman is different. Talk to your provider about it, and your risk is different depending on your situation. Low-dose therapy, also called vaginal estrogen therapy, which I use a lot for GSM, genitourinary syndrome. It's administered into the vagina, goes effective for both moisturizing and rebuilding tissue. Very little goes into the circulation, so the risks are low. And then there's another DHEA, intravaginal. It's a local hormone vaginal therapy. It's beneficial for treating sexual pain by vulvar and vaginal changes. So you have a lot of options. Sexuality, sexual dysfunction can be a major disruptive force. Between 17 and 45% of postmenopausal women say they find sex painful. There are 4 areas in which this may occur. And, it can affect, menopause can affect your desire, your arousal, orgasm, and sexual pain. So sexual desire, decreased libido, there's a reduced production of estrogen at menopause. It causes hot flashes and night sweats. So not having restful sleep might reduce your interest in sex. Falling estrogen levels result in vaginal dryness and thinning lining, making it painful. And then there's partner sexual problems. These might also affect desire, and factors such as changes in body image and self-esteem, as well as concerns about aging. Sexual interest after menopause also depends on your past level of sexual interest. So it's definitely something to talk about with your provider. Understand and share your sexual concerns with a healthcare professional can improve desire and sexual satisfaction. Healthcare professionals may help by referring you to a clinician or a counselor who specialize in treating sexual concerns, but we need to talk about it. These are some non-hormonal and hormonal therapies for low sexual desire. I don't want to get too detailed, but there are some out there. And safety is a concern, so you have to talk to your provider about the safety. And it depends on your overall health condition as well. Memory, cognitive function at midlife appears to be influenced by the stage of menopause and by menopause symptoms, and might be because of sleep difficulties and mood changes. These cognitive changes can be frightening for women who may fear Alzheimer's disease, but often it's not. So I know most women are concerned about their memory, and I think we all have a little bit of that, but sometimes it's because we have too much on our minds. Again, talk to your provider about it. Lifestyle measures. So for women who undergo natural menopause, hormone therapy is not recommended to improve cognition. There's been no studies that show it improves cognition. However, a number of lifestyle measures may improve memory or help prevent dementia, including an extensive social network, remaining physically and mentally active, getting plenty of sleep, which is sometimes difficult, but we have to work on that. Don't smoke, limit your alcohol, and increase dietary intake of omega-3 fatty acids, fatty fish, walnuts, flaxseed, chia seeds, and certain vitamins from natural foods. But extensive social networks, super important. Mood changes, they can be related to big swings in estrogen levels during perimenopause, but the precise mechanism isn't known. 4 in 10 women have some mood changes and mood swings. Hormone therapy may improve mood if prescribed for other menopausal symptoms. We don't just prescribe it for mood changes. Women appear to be particularly vulnerable to depression during perimenopause years and in the years immediately following menopause. There's some antidepressants that are very safe, and also we recommend psychotherapy with a social worker or a psychologist. Anxiety is highly prevalent also, with higher rates than men from adolescence through menopause, so sometimes this worsens during menopause. Hot flashes might exacerbate anxiety because they're unpredictable and can be embarrassing. Recognizing a problem is the first step to finding ways to cope. Although many stressors can't be altered, coping skills and strategies can enable a woman to meet life's challenges and create a renewed sense of self-confidence, balance, and harmony. Sleep disturbance is very common, refers to difficulty falling or staying asleep. It's a common experience during menopause. It might be due to hormonal changes. It could be from hot flashes. It could be sleep apnea, so you always want to get checked out by your doc. Insomnia can cause fatigue during the day, depression, poor exercise habits, poor eating habits, weight gain, and memory problems. So it's something you definitely want to address. What do you do? Non-medication, sleep hygiene, which is having a time before bed where you start to wind down, turn off all your phones and computers and kind of just sit and relax and read a book. No alcohol. Don't eat 3.5 hours before bedtime. And I put a whole list of things here to try. And absolutely, I think I've tried every single one of them because I have gone through insomnia during menopause, and actually, thank God, it stops and it goes away. But more sunlight during the day, no computer screens. There's some supplements here that are prescribed, and some are over the counter. And keep in mind, natural doesn't always mean safe. I gave you that website for all things supplements, very reputable, and talks about safety on all the supplements that you find. Weight gain, factors contributing to weight gain include less estrogen, lower metabolic rate, decreased energy levels and lifestyle choices. More than 43% of postmenopausal women have weight gain. Sometimes it's from a diet high in carbs and sugar. So it's a good time to reassess, look at, your exercise habits and try to improve your diet, more fruits, vegetables, proteins, lots of water. Heart health, for both men and women, cardiovascular disease, leading cause of death worldwide. 1 in 3 US women will die of heart disease, and more women than men. Menopause is associated with a significant increase in blood pressure and body mass index, so your risk for heart disease increases. Most cardiovascular disease in women occurs during the years after menopause, and cholesterol levels have been found to increase. So super important to have a preventive visit with a cardiologist and to think about all the lifestyle changes that we talked about. Take-home messages. Again, I know I said it, but every woman's menopause journey is unique. I have so many women that sail through. We have good conversations. They come for visits. They maybe see a therapist, change lifestyle, and menopause is very tolerable. Hormone therapy is an option for moderate to severe symptoms. You have to know that as well. And there's a lot of talk about hormone therapy more now than there was 5 or 10 years ago. There are also many non-hormonal medication options also. Take an active role and make informed decisions in your journey and find a provider who's knowledgeable. I know I said that's so important, has experience in caring for women. Emphasizing a life course approach to health and well-being, including sexual health and well-being, by ensuring that women have access to appropriate health information and services to promote healthy aging and high quality of life before, during, and after menopause. These are the references, and I think they're all sites you can just click on and get excellent, up-to-date, evidence-based information on menopause symptoms, perimenopause symptoms, everything from hot flashes to vaginal dryness to sexual health, everything that you need. Thank you so much.
Well, hi, everyone. Good afternoon. I'm Dr. Mona Saleh, and I'll start my portion of the presentation. One of the things that becomes more important to think about when we are headed towards menopause or getting older is cancers. Unfortunately, age is a big risk factor for cancer of a variety of organs, and the GYN cancers are no different. So today I'm going to speak about preventing and detecting gynecologic cancers. I don't have any disclosures. So the objectives of this talk are to identify the signs and symptoms of GYN cancers that should prompt further evaluation, identify what we call modifiable risk factors for GYN cancers, and identify interventions that can reduce your risk of GYN cancer. So I'm going to start with a very basic kind of diagram here. I'm sure everyone already knows this, but this is a diagram of the female reproductive system. Externally, there's the vulva, and here we see the vagina, the cervix, the uterus. The lining of the uterus is called the endometrium, also where a baby would grow, referred to as the womb sometimes. And then we have fallopian tubes and ovaries. So I'm going to talk about endometrial cancer, ovarian cancer, and cervical cancer. So this data is a little bit older, but cancer is a pretty significant cause of death among American females. So it's very important to know the signs and symptoms and know when to get care when it comes to this. Uterine cancer is typically cancer of the endometrial lining. This is the same lining that accumulates when a woman is in reproductive age, accumulates and then sheds as the menstrual period every month. Endometrial cancer is the most common gynecologic cancer in the United States. And we'll talk about some of the reasons why that is. There's about a 2.8% lifetime risk of endometrial cancer in American women. The average age of diagnosis is 62 years. Most women diagnosed with endometrial cancer are post-menopausal. They've already made that transition to menopause. 25% of women are premenopausal, And then 5 to 10% of women are particularly young, diagnosed under the age of 40. There's a variety of risk factors for endometrial cancer. There are various genetic inherited disorders, such as something called Lynch syndrome, that can increase your risk for endometrial cancer. Obesity and being overweight increases the risk of endometrial cancer significantly. Women that take a medication for breast cancer called tamoxifen have increased risk. There are a few other risk factors, including older age, nulliparity, which means never having had a pregnancy, going through having early menarche, having early age at the time you began getting your menstrual periods, and then having a late age at menopause. So having more periods in your life increases your risk of endometrial cancer. There are some protective factors against endometrial cancer. One of those is pregnancy, having a late start to your periods, or what's considered by most to be a late start over age 15, and having history of using oral contraceptive pills or birth control pills. This, I would say, is the most important slide in the presentation, and I'd like everybody to take particular note of the information in it. So 90% of women with endometrial cancer will experience abnormal vaginal bleeding. The most common symptom of this cancer is vaginal bleeding after menopause. This bleeding can take a variety of forms. It can be red, brown, pink. It can be one spot. It can be like a period. It can be just a little bit of spotting after wiping. It can happen once and never again. That is never normal. That's not normal. Any vaginal bleeding after menopause, no matter what color, how often, how much, please see your primary care physician or your gynecologist to discuss. If someone also, late menopause is one of the symptoms. So it's not really a symptom like that. For instance, if we have a patient that's 57 years old and still endorsing that she's still having periods, that should make a light bulb go off that maybe this is actually not a period. Maybe this is endometrial cancer or pre-cancer that's bleeding. For women that are still having regular periods, if they have a certain pattern of bleeding and then all of a sudden they're starting to get heavier periods, if women start to bleed between their periods, that should also prompt some concern. Some other symptoms of endometrial cancer are pelvic or abdominal pain, as well as unusual vaginal discharge. A vaginal discharge is different from the woman's typical. On exam, so when this cancer gets advanced, sometimes women can have a pelvic mass or an abdominal mass that can be noted on exam. Typically, part of the workup for this includes an ultrasound, and if someone has endometrial cancer, that endometrium is noted to be thickened on the ultrasound. This is something that's also very important. So when women are overweight or obese, that increases the risk of endometrial cancer, and I would like to explain why. As women, we have basically two sources of estrogen in our bodies. Our ovaries, when we are young and still having menstrual cycles, the ovaries produce most of the estrogen we have. Now, after menopause, the ovaries are no longer producing estrogen to that level. However, our fatty cells, the fat cells anywhere in our body, converts cholesterol to testosterone and then to estrogen. So if a person has more fatty tissue in their body, they are converting that cholesterol to estrogen at much higher rates. That estrogen is then going to stimulate the endometrial lining to change and change and change the same way that it does when a woman is younger and undergoing, the menstrual cycle. Every time there's a change in a cell, what we call a mutation, that mutation can become cancer. There's a risk that that change is a cancerous change. And once cells become cancer, they develop something called clonality, meaning they can continue to clone themselves and cause a cancer, which is problematic, of course. So Normal body mass index is under 25, which can seem like a very strict requirement, but really, above this, we see increased risks of endometrial cancer. Obesity is complex. It's not, it's difficult to overcome. It's multifactorial. 65% of the US population is overweight or obese. And being overweight or obese alone accounts for 20% of cancer deaths in American women. So this is something that is, is an issue that needs to be addressed. So this is something similar to what we spoke about. 40% of all endometrial cancers are attributed directly to obesity. When someone has obesity, it not only makes you higher risk to get this cancer, but also it affects kind of the treatment decisions. Thankfully, most endometrial cancers are diagnosed early, so they can be treated with surgery. However, if someone is very obese, they may not be safe to undergo surgery. If someone is very obese, they might develop diabetes, hypertension, other factors that would increase the risk of complications from surgery and anesthesia. Sometimes women with endometrial cancer are recommended to receive radiation after surgery. There can be some limitations with dosing the radiation and directing it to the right area when patients are significantly overweight or obese. Lynch syndrome is a genetic mutation that increases the risk of a variety of cancers. These include ovarian, gastric, small intestine, skin cancers, pancreatic cancers. What I would recommend is if a patient is diagnosed with Lynch syndrome, and we're, seeing a lot more private companies offer genetic testing. So when, not every patient who has had genetic testing really had a physician or a genetic counselor speak to them about what the results mean. So I always recommend to people, if you have genetic testing results that you obtain through a private company, that's no problem. Please bring it up to your physician, bring the results in so that you can be referred to a genetic counselor to really counsel you about what those results mean and what the next steps are. I encourage people to know their family history really well. So if you're thinking about your family tree and you're noticing, oh, this person had colon cancer, this person had ovarian cancer, this person had breast cancer, keep that in mind and bring it up at your next wellness visit, your next checkup, and see if you would be an appropriate person to see a genetic counselor for counseling and potentially for testing. So moving on to endometrial cancer prevention, really maintaining a healthy weight is going to be paramount to do this. Knowing the family history and, like we said, seeking genetic counseling if you feel that you have a significant amount of cancers in the family. When patients have BRCA mutations, BRCA mutations, we know that they're at higher risk of breast and ovarian cancers, but there is some emerging data that they may also be at slightly higher risk for uterine cancer of a more aggressive subtype. So, we do encourage knowing that as well. When someone has a type of genetic diagnosis like Lynch syndrome or like a BRCA mutation, we do recommend seeing them. These patients should see a GYN oncologist like myself for counseling, because once these patients have completed childbearing, we do recommend to do what's called risk-reducing surgery to take away that risk, essentially. So if someone has a higher genetic risk for uterine cancer, and we know it in advance, and we have no reason to think they have it now, just removing that organ will delete that risk for them. So that's some prevention that we can do there. So the take-home message for uterine cancer is that having an increased BMI leads to unopposed estrogen production. Post-menopausal bleeding always needs further evaluation. And I would like every person on this call to go home and tell their sister or their daughter or their mother, their girlfriends, tell someone else this so that we can get the word out. Postmenopausal bleeding always needs to be evaluated. Uterine cancer is diagnosed with a biopsy, which can be performed either in the office or in the operating room if needed. Most cancers of the uterus, thankfully, are diagnosed at stage 1 when the bleeding symptom is present and identified. There is no effective screening for uterine cancer, and know your family history. The next cancer or group of cancers that we're going to talk about are ovarian, fallopian tube, and primary peritoneal cancer. The peritoneum is the inner lining of the abdomen, and it is treated similarly to ovarian and fallopian tube cancers. These cancers are a bit more rare. The baseline risk of ovarian cancer in women in the US is about 1 in 70, or 1.5%. It's the 5th leading cause of cancer death in US women. So even though this is a less common cancer, this is a very aggressive cancer. This is known to be a difficult cancer. Most of these cases are diagnosed in advanced stage. The cure rates are not, are what we would call discouraging with surgery and chemotherapy. Still, the cure rates are not great. There unfortunately is no effective screening for ovarian cancer. A fair amount of ovarian cancers are ovarian, fallopian tube, and primary peritoneal cancers are hereditary, particularly when patients have a BRCA1 or 2 mutation, or have a female relative with ovarian cancer, particularly if it's a first-degree relative, such as a sister, a mother, a daughter. Protective factors are having taken birth control pills for 5 or more years in your life, as well as having had a hysterectomy in the past or a tubal ligation, tying the tubes when you're done having children. Ovarian cancer, typically when it's early, does not have any symptoms. In advanced stages, these symptoms can be due to just having a large mass, pain, urinary changes, changes in appetite, as well as bowel habit changes. There is about an average delay of diagnosis up to 12 months after symptom onset, and most women are diagnosed in stage 3 or 4. So if you are having these changes, please don't wait. Please see someone about them to get evaluated. We've found that receiving treatment from a gynecological oncologist for ovarian cancer is an evidence-based recommendation to reduce mortality from this disease, to reduce the risk of dying from ovarian cancer. And I think the vast majority of, we're in a state where there thankfully is a fair amount of GYN oncologists that would be at your service. So I think this is something that is typically managed effectively here. In terms of causes of hereditary ovarian cancer, BRCA mutations, specifically BRCA1 mutation, is a significant factor. BRCA2 mutation, less so. And then there's other rarer types of genetic changes that can lead to ovarian cancer. Let me just move this. Okay, so when patients have a BRCA mutation, their risk of a variety of cancers are elevated. Specifically, these relate to breast and ovarian cancer, prostate cancer in men, and pancreatic cancer in both men and women, and among a number of other cancers. So even though it's called the breast cancer gene, BRCA gene, it's important that if this is a result that a woman finds, that her, both male and female relatives are tested as well. The take-home message for ovarian cancer is that the symptoms are vague. There's no efficient way to screen the population. It is typically diagnosed in an advanced stage. Again, know your family history. And if there is concern that you have ovarian cancer, please see a GYN oncologist about it. This is our ribbon for ovarian cancer. Cervical cancer. So this cancer is diagnosed in women who are on average a bit younger than the other two cancers. So the average age is in the 40s. Um, this is a cancer that occurs and more commonly kills women who are African American as well. The cause of probably over 99% of cervical cancers is HPV, which stands for human papillomavirus. This is a sexually transmitted virus, transmitted not necessarily just through penetrative intercourse, but also through any kind of sexual touching at any point in your life. People, for instance, can be infected with HPV when they are in their 20s and then be totally fine until they are 60 and then develop some consequences of HPV. Risk factors to obtaining HPV, having multiple sexual partners or a high-risk sexual partner. Risk factors to kind of developing a cancer due to HPV include immunosuppression. So if someone has a compromised immune system for some reason, for instance, if they have lupus and they need to take an immune modifying treatment, or if they have HIV, or if they have cancer, another cancer, and their immune system is not working at its best, those patients are at high risk of developing HPV-associated cancer. Also, cigarette smoking is a risk factor for cervical cancer, but always typically with HPV as the causative agent. Symptoms of cervical cancer: bleeding after intercourse is the big one. Having excessive discharge from the vagina and abnormal bleeding between periods. Most women, unfortunately, will have no symptoms of cervical cancer. So when we go to the GYN or our primary care and we undergo a pap smear, that pap smear is screening for cervical cancer. And that pap smear is only screening for cervical cancer. It cannot screen for any of the other cancers that we spoke about today. So even if a person has no symptoms, hopefully she is getting her pap smears on time, and the pap smear is often what prompts further evaluation for cervical cancer. So if you have an HPV infection that is persistent, that is what can lead to cervical cancer. The kind of progression from having normal cervical cells to cancerous cervical cells due to HPV takes about 15 years. So it's not a rapidly developing type of cancer. We spoke about pap smears. Pap smears are really, a significant model for cancer screening. We're very thankful that this is something that exists and that we can all benefit from. Cervical cancer prevention, age-appropriate pap screening and HPV testing in women. But really the main thing is the HPV vaccine. This is a vaccine that's recommended and approved from ages 9 to 45 in both males and females. Typically at this point, this is something that's discussed in the pediatrician office. Ideally, this is a vaccine that's given prior to sexual debut. The vaccine cannot cause HPV infection, and the vaccine cannot cause cancer. Receiving the HPV vaccine produces higher levels of antibodies than having a natural HPV infection and developing antibodies as a result. The only HPV vaccine that exists in the US is this one. It protects against 9 strains of HPV. Well, this is the only vaccine that exists now, currently. Previously, we had ones that covered for 2 strains and 4 strains, but now it's just Gardasil only, and it covers 9 strains of HPV. When you receive this vaccine when you are younger, prior to the 15th birthday, it's only 2 doses. Anytime after that, it is a 3-dose vaccine. Really, the only people that shouldn't receive an HPV vaccine are those who have an allergy to, a prior dose of it, people with an allergy to yeast, or these other substances that are here. If someone is, not feeling well, they have a cold or, some other viral illness, wait until that improves before getting vaccinated. We don't typically recommend giving the vaccine to pregnant women, but I have certainly given it postpartum and during breastfeeding, and there's no reason to think that is not safe. It works very well. In fact, the US doesn't have great uptake of HPV vaccination since it debuted on the market in the early 2000s, I think it was. But in countries that do have very good vaccination programs, such as New Zealand, they have essentially eliminated cervical cancer. So we hope to get there too. This data is a little bit older, but essentially when this vaccine first came out, there was significant concern in a number of, groups. There were some parents who were concerned that giving the child this vaccine would cause children to become more promiscuous, and things like that. But, a number of studies have looked into that specifically and have found that that is not the case. So the take-home message for cervical cancer here is to please vaccinate your children before onset of sexual activity, engage in age-appropriate cervical cancer screening with pap smears and HPV testing, and stop smoking. So the summary here for my talk is that 40% of endometrial cancers are preventable. About 5-10% of ovarian and fallopian tube cancers are potentially preventable, and over 95%, and I would argue that number is probably closer to 99% of cervical cancers are preventable. If you have any questions, please write them in the chat or in the Q&A as previously discussed. I work at Capitol Health. If you have a GYN cancer diagnosis and would like to see me, this is the phone number for my office. Thank you so much.
Okay. Thank you so much to Dr. Bornhoeft and Dr. Saleh. I'm not sure I'm seeing any questions, but I do have a question, and it's about how very few symptoms are recognizable or how often people are asymptomatic. Is that not so with other cancers? Is it more so with this particular cancer? And if you have a question, please do put it into the chat. We will get to it.
I would say particularly for ovarian cancer, this is a pretty silent cancer, more so than cancers of other body sites. It's difficult because it's entirely an internal organ. There's nothing externally really that you can see in the early stages, and the female pelvis can hold really big masses and you wouldn't know it. If you think about when women are pregnant, sometimes women are 6 months pregnant, 7 months pregnant, and you can't tell from the outside, but the baby's there. It's the same when people develop a cancer of the GYN organs. When it's an internal organ, really these cancers can grow to significant sizes, and if you're looking at the person, you can't tell that anything is wrong, and they might not feel that anything is wrong. They might not feel any different. So it's important to kind of really be in tune with our bodies there.
Well, it looks like a flurry of questions have come in through the Q&A function. The first one is, does the Gardasil vaccine provide lifetime coverage of HPV prevention, or do you need to get the vaccine again after a number of years, say 15 or 20 years?
Yes, the Gardasil vaccine should provide lifetime prevention of HPV. You do not need to redose. When the younger you are when you're vaccinated, the more robust of an immune response that you will have, and that will be carried through your life, which is why we really encourage people to vaccinate children. As young as age 9, but typically I think pediatricians will counsel at about age 11 to start this.
Very good to know. If you, the next question, if you have a family history of prostate cancer, say through your father, but no other cancers in the immediate family, would you recommend still getting tested for the BRCA gene?
Yeah, that is a good question. So, a few different factors to consider there. One of them is the age at which the father was diagnosed with prostate cancer. A man diagnosed with prostate cancer at age 75. That's a different genetic situation than a man who has been diagnosed with prostate cancer at age 39. What I would encourage is if, someone is concerned about their genetic risk, See a genetic counselor, ask for a genetic counselor referral because, and just know your family history going in because they're going to make such a detailed, what we call a pedigree, very detailed pedigree, and they'll give you really, the best answer for that. And at this point, genetic testing is so, widely available. If somebody wants to be tested, that I'm sure that can be arranged.
Well, that sounds very good to know. I wouldn't have thought of that through the father. If you have a diagnosis of stage 4 endometriosis, how does this affect your ovarian cancer risk?
Yes, so endometriosis does raise the risk of two types of ovarian cancer called endometrioid and clear cell ovarian cancer. Um, it raises it slightly above the typical the standard population. So there is a small increase in risk there, but it's not an overwhelming increase.
Next question, have you heard of any information about motor delays as a result of the HPV vaccine? Not sure what that means.
Like, yeah, I think I understand. So I personally I'm not aware of the HPV vaccine causing motor delays. And then I see the rest of your question. That if you have a teen with cerebral palsy, is that a contraindication? No, that's not a contraindication to receiving the HPV vaccine.
Continued from uh, talking about contradictions, goodness, what a word. If a person has a teen with cerebral palsy, are there
No,
contradictions?
no contraindication there.
Next question, is there a window of opportunity for taking and realizing the benefits of HRT? I suppose this might be for Dr. Bornhoeft. In other words, is there an age where it's too late for HRT?
So that's a great question, and that was part of the research that was done, and they found that the as close to menopause as possible, ideally within 5 years of menopause, and absolutely no more than 10 years. Once you're 10 years out of menopause, the risks increase and the risk outweighs the benefit.
Very good information to know. I do have another question about menopause. You mentioned that with osteoporosis, that at 30 years, you sort of just stop building bone strength and you sort of have to maintain it afterwards. What are the things that would sort of, you mentioned calcium and I think vitamin D. Are there any other very good fruits or vegetables or specific types of foods that would help with that or supplements? I ask because I'm reaching 30, so
So yeah, that's an important factor that we should be talking about are young women, because up until 30, you want to make sure that calcium intake is adequate. So calcium ideally is milk, yogurt, and cheese, dairy products. It's also in some greens such as kale and broccoli. You can, if you're lactose intolerant and you just don't take in any dairy, then you can do calcium supplements. Also, vitamin D comes from sunlight, ideally 15 minutes of sunlight every day, but now everyone is consumed with worry about skin cancer, so we don't get enough sunlight. So a lot of my women take supplements of vitamin D. Um, so you have about until 35 to build your bones up. So if you're getting adequate calcium and vitamin D, your bones are going to be strong, and that's great. But after that, you have to make sure you replace premenopausal 1,000 milligrams of calcium every day, post-menopausal 1,200 milligrams of calcium every day. Also, bone strengthening exercises have proven to strengthen bones. So power walking, weightlifting, running, also helps your bones and helps prevent osteoporosis.
thank you for answering that. There's another question about cancers. Could the reoccurrence of uterine fibroids increase the risk of uterine cancer? Dr. Saleh.
No, no. Fibroids are a separate benign process that's very common. Fibroids do not turn into cancer. So yeah, it's unfortunate that they recurred, but
Mhm. Another one, follow up to the HPV conversation. How long does it take for the body to clear HPV? Which,
yes, that's a good question. Most people, when infected with HPV, will clear it on their own, typically within the year, within 1 year.
right, so we've reached the hour. So if anybody has to, some people are on their lunch break, they have to go back to work immediately or they have to leave. Feel free to do so. We will be making this recording available. If you're able to stay, please do stay. And we can move on to the next question. If you have a family history of ovarian cancer, suffer from endometriosis with multiple, well, this is a long question. Endometriosis.
Yeah, I see it here.
Yeah, frequently. Should you be getting ultrasounds to monitor for ovarian cancer? And then a sort of separate question
Hmm.
about low dose birth control. Get to that one next.
So the birth control will significantly reduce your risk of ovarian cancer, particularly with that family history. So I would definitely really recommend that. It doesn't, you know, this is like a very detailed question, so definitely would recommend speaking to your OBGYN about this specifically. And if you would like to see a gynecologic oncologist, you have a totally valid reason to do so. But would definitely recommend the birth control pill if you have if there's no medical reason for you not to take it. It's not possible to screen, unfortunately, for ovarian cancer, but with that, kind of history, probably an ultrasound once a year, would be my recommendation there. But again, that's a very specific situation, so really should see someone who knows you well.
That's good to know that you can take those very specific questions to somebody and not sort of feel ashamed about it. Let's see. It looks like we don't have any more questions in the chat or in the Q&A for now. Let me see. Okay. Thanks to everyone who's attended, if no one's putting in some last minute questions. And thank you to Dr. Bornhoeft and Dr. Saleh for extremely important combination presentation. Do either of you have any last minute remarks or information you'd like to provide on the content of your presentation, sort of as a last push?
Thank you for having us.
Thank you so much. I also work at Capitol Health, so I'm very reachable.
That seems to be it. Again, thank you so much. This Zoom session is over. Thank you for everyone participating. When you exit out of the Zoom meeting, you will be asked to fill out a survey. Please do. It really helps us plan for future programming. Yeah, good afternoon. This
Thank you.
concludes today's session. All right. Thank you all. Bye-bye.